I am finally back to do another live. I know it's been a few weeks because I wasn't anticipating after the last one that I would get knocked down with a virus and then not actually have a voice for at least 3 days. So yes, I am back and I am going to answer a couple of the questions that I lobbed at you in the stories after our last catch up online. So basically, the last time we caught up was in regards to the fallout from the APOD conference with the Good Feet store, and thankfully that they have been withdrawn from being an exhibitor at the conference. That's fantastic. That's all settled down. Many people were cranky. Great resolution. So what are we going to be chatting about today? There are a couple of really good questions that came through from, like I said, the Instagram story that I popped up and people submitted their questions. And one of them in particular, it probably deserves its own time. And given that I'm just waiting until the sideways rain stops here in Adelaide before I take my dog out for a walk, I probably won't get time to tackle that one. So that question was a fantastic one, but it was also quite broad. So it was asking about MSK injuries in women's health. So there is a very, very broad stroke that covers, because we can be talking about just general MSK injuries, and in relation to menstrual cycle function, we can be talking about MSK injuries in regards to perimenopause, postmenopause, and when estrogen decides to eject itself from the situation. So that one, great question, but I will put a pin in it for probably another day. But the other questions that we're going to tackle are probably a little bit more of the softball ones and more of a gentle lead into me coming back from being sick. So if anyone does have any questions that they want to lob at me, throw them in the question box, which is down on the bottom right, little question mark. But until we get there, all right, we'll start with a nice easy one. So one of the questions that came through, because when I posted the story, it was literally just a video in the background of me doing leg extensions. What do I do for leg day? Today, not much, because I'm actually quite sore thanks to the city of Unley having their obstacle course, also known as their footpaths, me failing that. So took much skin off my hands yesterday when I was running. And it turns out when I was at the gym today, I was actually quite sore everywhere: shoulders, chest, wrist, triceps. Legs aren't that banged up. My runners are, and my running shorts are torn. Do have some nice bruises, but anyway. Okay, so what do I do for leg day? Talking a little bit more broad stroke with strength training. So I go to the gym 2, maybe 3 times a week. How I split up my training, because I do a fair amount of running, so I'll run sort of circa 50 to 65 Ks a week. And this actually will lead into having a little bit of a sort of thought about the transition that we go through when we're working with patients, going from rehab mode to performance mode. So for me personally, I do legs on both days. So I do what we call a 2-day split program. So mine is a front back. So you can split up your training any which way. That is how I do it. So a 2-day split essentially means I do the same thing day 1, and then different on day 2, and then just recycle that. So mine's a front back. So day 1 is anterior shoulders, chest, triceps, quads. And then back day is lots of back, because I do a lot of computer work and podiatry clinical work. Essentially, I spend a lot of time hunched over, so I do a truckload for back day. So it's almost twice as big as what my front day is. So for back, I do essentially everything in the back. So a lot of reverse flies, deadlifts, hamstrings, calf muscles. If I do any core work, that tends to happen on the Monday. So what it looks like for me is I also do what we call a superset. So with supersets, so you've got your front back split. That makes it so you can get through basically every muscle group at least once a week. But then I do supersets. Very good for time. So that's where you cluster 2 exercises together. You can do trisets, but essentially with me, with strength training, if you're doing a superset, that's essentially, instead of your normal strength training where you might do a lift and then rest for 60 seconds to 2 minutes, or even longer if you're doing power lifting, but instead of that 60, 90, 120 seconds being a pure rest, you'll actually do another exercise in that. So I'll do squats, and then my superset for that is bench press. And then the next superset, so basically you go squat, bench, squat, bench, squat, bench, squat, bench. I do 4. And then I'll move on and I'll do Smith machine split squats and cable flies. Then I'll go on to do leg extension tricep dips, and then I'll do a tricep where I'm basically doing landmine shoulder presses, tricep extensions, and some ab work. So that is my front day, basically. And then back day, I'll start off, I do hip thrusts and couple that with lat pull downs. Then I'll move on to single leg Romanian deadlifts, coupled with a sort of standing rotation, kind of lat pull down into a row. Then that will get supersetted with cable row, seated calf raise, and then rear flies coupled with standing calf raises. So that is my leg day. Now, the sets and reps that I do for that, so I typically do 4 sets for the bigger groups, and then I'll whittle it down to 3 sets for the last ones. So for my upper body, and this is where we get into a little bit of consideration when we're thinking rehab mode and performance mode. So when it comes to because I run a lot, because when it comes to running, if we're doing hypertrophy rep ranges, so it's not a distinct cutoff, but there's a little bit of a bleed over. So when you've got more of your sort of powerlifting, that's sort of 1 to 3 repetitions, and then when you go more into strength, it's kind of 2 to 5, and then once you're sort of 6 and above, that's when you start to bleed more into hypertrophy, and then beyond sort of 10-ish, you're heading more into endurance territory. So when you do something that is a lower repetition range and a higher external load or weight, that's more what we call neurologically demanding. So essentially with that, it means that the nervous system has a lot more load on it to recruit as many muscle fibers as possible to overcome that force. So that's why you see power lifters, they might lift a metric shit ton of weight, but then they only do 1 or 2 repetitions, and then they'll sit playing on their phone for 5 minutes in between their next set, because they need time for that whole neurochemical element to recharge itself. But then if you're doing more endurance or hypertrophy ranges, the rest breaks in between sets is smaller, but you'll often need longer to recover in the subsequent days after that. So for me, I find that sticking more in the strength range for legs is better for me because it doesn't impact my running on the subsequent days. So for legs, I'll do a higher load. So for squats, so I weigh 57-ish kilos. For squats, I'll be squatting sort of 40 to 50 kilos for my warm-up, and then I'll head into sort of 60, 65 for my actual strength work. And then that's where I am able to maintain form, can do full range that I want, and can do sort of 5 to 6 repetitions, and my form doesn't break down. Can go a little bit higher, but form breaks down after sort of at 65 kilo-ish, but that's more than my body weight, so that's fine. And then similar with hip thrust. So hip thrust, I'll be doing sort of between 70, 80 kilos at the upper limit, but again, keeping that under that 7 repetition range. But then when it comes to upper body, I'll just go until I'm gassed. So that's normally sort of 10, 12, 13, 14 repetitions. Because what you'll find is when you're doing strength training, especially for the legs, if you're going back to running, strength training that is more metabolically demanding, that's where you're getting more of the eccentric load and repetitions, and it takes longer to recover at a cellular level for that tissue repair. That's when you can have that recovery sort of impact on performance, or the impact on performance whilst you're recovering from that in the days after. So why I wanted to pin that for when we're prescribing exercises in a rehabilitation sense is a lot of clinicians will often forget or neglect to modify some of the load metrics when it comes to exercise prescription as someone's progressing through their rehab. So when we've got someone who has a low level of function at the early stage of rehab, they might be able to do a really high frequency and high number of repetitions. So let's say it's a unweighted seated calf raise or even a bodyweight bilateral calf raise. Some people might be able to do 20, 30, 40 of them. But then what a lot of clinicians forget is this patient, say it's Achilles tendinopathy, plantar heel pain, whatever it is, whatever they've been prescribing the exercises for, okay, it might have been bilateral calf raises, 4 sets, 20 repetitions, and they've built up to being able to do that daily. Hi, everyone that's jumped on. So when people are they're moving through their rehab, so they might have been able to achieve that 4 sets, 20 repetitions, and that's completely fine. Then they come back, the clinician goes, that's fantastic, let's progress that to single leg. So you're going from having sort of 50-50 body weight split for the most part, bilateral, and it's essentially 80 repetitions that they're doing. And then you've just essentially doubled that because they're going single leg, but you haven't modified or dropped them back down with their set and rep range for them to build up. That's where we can fall into that trap of overdosing them. So oftentimes what we may need to do is essentially give them a little bit of a guide. So they may have built up again to that bilateral 4 sets, 20 repetitions every single day for the calf raise. And then we just go, okay, we'll just do unilateral calf raises, but we're keeping the frequency the same, we're keeping the sets the same, we're keeping the repetitions the same. So you've essentially doubled it and not modified anything else. So what I typically do is for people, if it depends on the dosage metric. So if you remember, there's 9 different ways that we can modify a strength exercise: sets, reps, tempo, range, joint angles, complexity. I can't remember some of the other ones, but anyway, that's enough examples for now. Okay, so let's say we're progressing someone from bilateral 4x20 calf raises. What I would do is take them from doing it every day to potentially every second or third day, and then see how they go from there. Once they can build up, if it is, we're keeping that metric at 4x20, once they can build up to that every third day and there's no issue, then we might introduce it every second day. Once they can build up to that, then might introduce it every day. Probably wouldn't introduce it every day, but that's what I would do. So it's an important consideration that whenever you are increasing someone's load via exercises, always consider the amount of time that they're going to need to recover from that exercise. So if it has been bilateral 4x20 every day, and then you progress it to unilateral, what you might do is go, okay, well, instead of it being 4x20 every day, it might turn into 4x10 every second day. See how you go with that, and then progress up from there. So main consideration is just making sure as soon as you up someone's dose, you may need to modify the frequency or the other dosage metrics. Very important consideration. So that's a little bit of a segue, but that was a good question from the other week. What do I do for leg day? That answered that, and hopefully it's given you a little bit of a nuanced understanding of where we may need to modify some exercises. So there are a couple of free resources on the P3 platform where I do talk about exercise and rehab dosage, ways that you can modify dose, monitor dose without sets and reps using the VASP model. And then if you are part of the online courses, exercise therapies and podiatric practice, or the plantar heel pain one, lots of modules in there where we talk about exercise prescription and dosage. Okay, so that hopefully answers that question. Now, there was another question which I'm just going to mention it, but I'm not going to do anything today because I'm sitting down, I'm comfy, and again, I'm sore. So one of the other questions was, not sure if it's a live thing, but can you do exercise demos? I will be doing some. It's just not going to happen today. And the reason it's not going to happen today, again, I'm a bit sore and busted up, but I have been thinking of a couple of ones. So I did the little mobility mojo challenge a few weeks ago where everyone got mooned by my dog. Apologise for that. But anyway, and that was being able to get up off the floor from cross-legged to standing without any external assistance. Now, when I was doing some exercise demos with a few patients the other week, I noticed that, and this is where birthdays catch up to you, right? I was doing single leg balance, eyes open, that's fine. And then I did single leg balance, eyes closed. A lot more deficits have developed with me, time-wise, in my ability to do that than previously. So there are a couple of other exercises that I'll do. So yes, I'll be doing some exercise demos. And now that I've started with my podaitry as one of the senior clinicians there, I am going to be doing a few more little bits and bobs on social media. So you will see a few exercise demos coming up, but not today. We'll pin that in there. And yes, I will be doing some mobility and just general exercise challenges, because it'll give me a little bit of motivation to improve some of the areas that I've become a little bit more deficit on, that I need to get a handle on, because the passage of time doesn't stop, and neither does our functional decline. So we just want to put a pin in that. Okay. Another question that came through that I did laugh at this was, can you do more takedowns of shit clinicians and businesses? So again, I'm not the podiatry police. There are plenty of social media posts that I have saved and tagged, tagged myself in for future reference. Sorry, that is my dog. Tagged for future reference, because there's a lot of misinformation out there that I do want to tackle in some way, shape or form. So again, I'm not the podiatry police, so I'm not going to go after shit clinicians and businesses, because that's not my job. If there is something that you really have a concern about, APRA, lodge a complaint. That is what they're there for. There's advertising guidelines. However, misinformation, tons that I've already saved, tons that I want to tackle. And yes, if you want to continue sending all of those bits and pieces through to me, yes, continue doing that, because I will add it to the list. Will I actually get to it? Maybe, maybe not. We'll see. Okay. Now, there's the last one was, and the answer is yes, lots. But I'll give you the question first. So what's a treatment that I drank the Kool-Aid on? Now, so basically what this means is, what's a treatment modality or intervention that I went hell-bent on, like we all do? And again, the answer is lots, because I've been practicing for a very long time, 18 years. Oh my God. So what that question means is, what's a treatment that you drank the Kool-Aid on? Is essentially, what is something that you leant very hard into, or bought into the bullshit maybe a little bit more than what you should have. Now, there are a few, it's the pendulum swing, and we see it just in general with almost any modality that becomes in vogue, right? So you'll see that there'll be foot joint mobilizations. You go to a course and yes, you're flooded with 2, 3, 4 days of phenomenal amounts of information, and you leave, the clinical skill is sort of fresh in your hands, in your mind, and then you go back to the clinic and you really use that time after time after time after time with a whole heap of patients. But then often you'll sort of settle into figuring out who it may help, who it may not be that suited for. But there's been so many of them. Even strength training and exercise prescription is one that I drank the Kool-Aid on, because it was the quote, like, you can't go wrong getting strong. Yes, that's true, but not everyone needs strengthening exercises. Dosed movement is completely fine. So a perfect example that I saw around circa 2015, so by then I'd learnt a little bit, but 2015 with the Rathleff paper, high load strengthening for plantar fasciopathy. So what was happening with there is, we've figured out that doing high load strengthening exercises for plantar heel pain is phenomenal for it. So then what you were seeing is almost every patient that came into a clinic and was seeing a podiatrist, physiotherapist, whoever it was, they were all getting these exercises. Yes, similar to the research, it would work really well for some people, but then it would be complete nightmare fuel for others, because not everyone needs the high load strengthening. So strengthening on its own, yes, that's one that I drank the Kool-Aid on. Early on in the piece, I probably prescribed a lot more than I typically would. And then now it's sort of petered down into, no, sometimes I don't need to give anyone any exercise. Sometimes it literally is just a little bit of advice around movement, load management. And sometimes it's just dosed movement, change your shoes, go for a walk. And we're dosing that instead of being really prescriptive with the exercise. So that is one. Other ones, foot joint mobilizations, have done that. Do I still do them? Yes, sometimes I do. Dry needling. Initially, when I first did the course, that was the first course I did after I graduated. So, 18 years I've been using acupuncture needles and performing dry needling. Initially, like everything, lots of people got it. Now it's a very nuanced application. So I can go months and not do dry needling for anyone, and then I might do a few sessions for some people. Shockwave, that was another one. What else? Oh, there was one. What was it called? Because I have done, as many of you might know, I have done a lot of CPD that's outside of the podiatry lens, which I do think that us learning from other health disciplines is invaluable, because everyone will look at things slightly different to what we're taught and outside of our lens. So getting those differences of opinions and that nuance in how we can look at things, I think is very beneficial. Counter strain therapy, that was one. So I actually do think that for some of those patients that are more sort of somatic and sort of internalized with a lot of their stress, and they're having a lot of they kind of fall into that psychosocial patient avatar where there's a lot of stress, they're very tense, and they're often the clients that you see that their physical symptoms or self-reported symptoms don't really marry up with what you might be assessing physically with them. So sometimes counter-strain therapy in some of those instances, or similar passive like massage type therapies, might be beneficial. But yeah, there were a lot of people that I probably, after that weekend course, for a few weeks, there was a lot of people getting counter-strain therapy, and then it sort of petered down into very few. I would actually be interested to know, those listening, what's a treatment that you guys have drunk the Kool-Aid on? So there's, basically that's with me. Probably where I've, again, like I said, drunk the Kool-Aid on. So it's lots of different treatments, and I don't think it's necessarily buying into a lot of bullshit, because I think hopefully when there's CPD courses that are run by institution or associations, that there is some form of quality control. I know occasionally there's some that slip through the cracks and then complaints get raised about those courses. But I think for the most part, a lot of the education out there isn't too bad. The real outlier things I've never fallen into. So I know there's some clinicians that do things like hair follicle testing and all this random crap that, I probably wouldn't go near that Kool-Aid. So that is my little rundown of my live today, and it has actually stopped raining, so now I am going to take my dog for a walk so she doesn't lose her mind, which will subsequently make me lose my mind. So that is my question to the people who are either listening now or watching later. What is something that you have also drunk the Kool-Aid on treatment-wise? And also drop a comment, and I will actually drop a comment under this video for what else you would like me to touch on. Like I said, I am going to circle back and do a little bit of a discussion, particularly on MSK injuries and women's health, for the other question that was presented a few weeks back, because it is important to talk about, but again, it's a topic in its own right. And there's a multitude of things that we can discuss with this. Estrogen, menstrual cycles, perimenopause, postmenopause, and so on. But until then, if there is anything that you've drunk the Kool-Aid on, leave a comment. And I will post some story questions for you to submit, some other topics that we might have a little brief chitty chat on. And yes, I am back in the land of the living. I have a voice. I have not much skin on my hands or my thigh. But anyway, thank you for those that have jumped on. Brief chat, say hi, and I'll see you guys next time.